Note the timeline is sped up. The heart doesn't enlarge like a water balloon that you're filling up. So that's accelerated. But that's a result of the persistent need to increase heart rate. That's a training effect, essentially. Yeah, Leanne.
To a certain point, though, wouldn't like more heart muscle help?
More heart muscle is a compensation to overcome the obstruction or overcome whatever the cause of the inefficiency is, but that increased muscle mass takes up space within the ventricle. There's not so much space for the heart to expand into, and so it compromises the amount of blood that can be pumped. Overall, the net result is lower cardiac output.
So it lowers the volume of the ventricle?
Yeah.
Oh.
Yeah, stroke volume is compromised.
So why doesn't, when the heart muscle expands, why doesn't it push outward instead of inward? Is that because the pericardium kind of...
Yes, it's limited.
Yeah.
Yeah. Yeah. Yeah.
Can you
It does.
elaborate on like the fluid retention portion?
We're going to get to it.
Oh, okay.
Absolutely. So we're essentially following this in our next series of slides. This is just to preface today's topic and give you the story before we explore in detail. So, congestive heart failure describes some persistent inability to maintain cardiac output. There are things that occur whereby the heart tries to correct this inability to maintain cardiac output. It's just not effective. And the video alluded to a few different causes, a few different classes of causes. And the first one might be an inability to pump blood because the tissue itself is undersupplied. And so a common reason why that might occur is if there are any coronary artery blockages, plaques in the coronary arteries, a reduction in flow, which simply means there's less nutrients, substrate, oxygen that are delivered to the heart muscle itself. So in this situation, what would happen? Contraction would become weaker, stroke volume would be compromised, the brain senses, or the cardiovascular centers sense that there's inability to maintain cardiac output, and we try to increase preload contractility and increase cardiac output. That doesn't get around the fact that there's a reduced supply here to the cardiac tissue itself. Another possible mechanism would be something we're more likely to see. Well, we're likely to see both of these with the recent increase in the incidence of sedentary and chronic disease, but hypertension. Hypertension, persistent hypertension, high blood pressure, increases afterload, which is the work that the heart must do to overcome pressure in the arteries and pump blood. If afterload is too high chronically, then stroke volume is compromised on every beat, and so the heart must try to pump more blood, pump more forcefully, and this is where we typically see the characteristic enlargement of the left ventricle. And notice here, at least in cartoon form, you can see the musculature of the left ventricle wall encroaching and closing off the lumen, or the space to load and pump blood. So a few different reasons why the inability to pump blood might occur. In both situations, normal heart function is inadequate, and we need to find a way to compensate for it. The processes we described on Tuesday, normally, our compensation would be enough. In both of these cases, acute compensation is not enough. Can't restore high blood pressure back to normal by increasing heart rate. You can't get rid of coronary plaques by increasing heart rate. So we try. The heart doesn't know what the reason is. It just knows that the flow being produced by the heart is inadequate. So we try to compensate. What happens? If flow is inadequate, we normally observe a decrease in pressure. Less pressure for what we should observe according to our standard tables, the comparative tables that the Cardiovascular Center is comparing to. And so if the inability to pump blood persists, if flow is too low, we can try to increase flow, and or we can try to increase resistance. So what we'll often do is constrict the periphery, increase total peripheral resistance to help maintain pressure. Both of these mechanisms would occur regardless of the source of the inability. But you can imagine how in a case where hypertension persists, if you try to further constrict the periphery, you're only stimulating hypertension and worsening the condition. Overall, the inability, it's a downward spiral where the inability to pump blood perpetuates. So we're trying to increase cardiac output through some of the reasons or some of the means that we talked about last class. We try to constrict the periphery to maintain pressure. And in essence, what this says is where normally afterload is overridden, in this situation, afterload is a great stress on the heart that is chronically apparent, is always there. Where afterload is obviously overridden, we use the example of exercise in a healthy individual. Afterload is a necessary side effect of stimulating the cardiac muscle and trying to increase heart rate and cardiac output. Whereas as that's normally overridden in a healthy individual, here it's a persistent obstacle for the heart. And so with persistent increased afterload, the work required by the heart to maintain cardiac output is increased. With every single beat, it has to do more work to eject the same amount of blood. And it simply can't do that. Eventually. It might keep up with it at first, but persistently over time, it can't maintain that workload. What we use to describe this phenomenon, or the workload of the heart, is what we'll call it's often called the double product, or the cardiac product, more specifically the rate pressure product, which is the pressure times heart rate. It's a measure of the cardiac workload, a lot like VO2 is a measure of whole body workload during exercise. This measures the amount of work the heart has to do. With every beat, the heart has to overcome a certain pressure to pump blood. And if pressure is high because we're vasoconstricting the periphery, and we're trying to compensate for an inadequate flow by increasing heart rate, well, of course, rate pressure product goes up. And normally, 20,000 to 25,000 is an average number. That's an average rate pressure product that we would expect in a healthy individual. But as soon as we start to creep up north of 25,000, over 30,000, and I guess that's millimeters of mercury per minute, I suppose. Regardless, it's just a number that describes the cardiac workload. As soon as that number becomes too high, it's an indicator the heart will fatigue or hypertrophy to compensate, but eventually fatigue. So like we would train, our muscles, our cardiorespiratory system would train if we worked at a higher workload intermittently. We're not doing that 24 hours a day. The heart tries to train to overcome this increase in afterload and the work that it has to do. Clearly, this is a great example of overtraining. We don't do 24 hours a day of training like the heart would in this case, and eventually the heart fatigues, stroke volume is cut off, and becomes weaker. So what happens to our pressure volume loop here, the normal situation that we described with isovolumetric contraction, isovolumetric relaxation, adequate normal stroke volume, what happens? If we fast forward in a situation with high afterload, where the heart has hypertrophied, we're trying to increase heart rate, and we're also trying to increase preload through fluid absorption, which we'll talk about in a second, we see a response somewhat like this. We retain fluid in an attempt to help the heart pump more blood with each beat. So higher end diastolic volume, much higher end diastolic volume. We attempt to increase heart rate by increasing preload. The heart continues its normal cardiac cycle, but is much weaker. The ability to hypertrophy and train the heart has only made it weaker. It's fatiguing at this point where stroke volume is ultimately compromised. It's quite low. We have both a higher end diastolic volume and a higher end systolic volume. I'm trying to think of how to describe this with length tension, but you can think of it as the elastic property of the heart is being compromised. Where normally if we increased or stretched the cardiac muscle, there would be some recoil to help push blood out. In this situation where that's chronically observed, the elastic recoil itself is wearing off. The tension is wearing off within the cardiac muscle. So the tissue becomes weaker. We have this persistent overfilling, a compromised stroke volume because of the inability of the heart muscle to contract and expel blood, and overall further reduction in cardiac output. Yeah, Tom?
How can we see a higher end diastolic volume if we also have hypertrophy of the left ventricle? So wouldn't that reduce the size of the lumen, so then decrease?
That's a good point. Why is there a higher end diastolic volume if the lumen itself is smaller?
Would this be before hypertrophy?
So I understand that the fluid retention is going to increase
Yeah.
the amount of blood.
It would make a lot of sense if this were before hypertrophy, but I'm quite positive this is supposed to be a trace after hypertrophy when the heart muscle is fatigued. So this is, I don't have the answer to that right now. That's a really good point. Let me look into that and I'll bring that back to you next class, okay?
Yep.
Because this says the compromise comes from incomplete contraction, not from incomplete filling, which is the scenario we set up with hypertrophy. And it would make a lot of sense, like Peter pointed out, if this is before hypertrophy. And if this were the case, where we have incomplete stroke volume, the necessity to increase heart rate is obvious and apparent. The increase in heart rate would then train the heart and then induce hypertrophy. So I could see how this would precede hypertrophy. I'm pretty sure that it's not supposed to, but let me check on that for you. Yeah.
So just to recap, so like for example, somebody has plaques in their arteries, so the heart needs to pump like harder to get the blood out, and then because of that, the ventricle hypertrophies, and then because of hypertrophy, you have less stroke volume, so you retain more fluid to increase stroke volume.
Pretty close. So what will happen in a plaque scenario? The heart becomes weaker and contraction is less forceful. Cardiac output is compromised, and so constriction initially tries to compensate. All of the arteries and the rest of the body clamp up to maintain pressure. And it works. Pressure goes back up. But now that weak heart that can't contract forcefully because of the plaques has to work against the higher systemic pressure. And then the situation we're describing here occurs. Higher pressure, higher cardiac workload, higher rate pressure product. Eventually hypertrophy, but because the heart muscle is still weak and unable to contract and expel blood at the rate required, we have this continual progressive compromise in cardiac output, if that makes sense. And then the continual attempts to constrict to maintain pressure. And so one begets the other, and it's a vicious cycle where eventually the heart simply stops working. It's unable to pump adequate flow. Does that make sense? Okay. So overall, constriction is probably one of the more acute responses, global constriction. But if the insufficient cardiac output persists, this is where the fluid retention comes back in. Fluid retention is a chronic response to help boost mean arterial pressure. To not only help boost mean arterial pressure, but also to sustain preload, to help return adequate fluid to the heart to be pumped to the rest of the body. And while this process means well, cramming more fluid into a confined space has the unfortunate side effect of also increasing pressure, also increasing the workload against which the heart has to pump. So the cascade, one of the main cascades, is the renin-angiotensin-aldosterone system that we've alluded to before, that I think you know at least from anatomy and physiology. But in a situation where fluid retention is required, and in this scenario it's required to help maintain preload and to help the heart or to supply the heart with blood to be able to maintain flow. Here we have renin, which converts angiotensin to angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme, which we've heard of before. That was in the endothelium of the lung, and that was one of the reasons or one of the mechanisms that we could help control blood pressure. ACE inhibitors, angiotensin converting enzyme inhibitors, prevent this conversion, which in a situation of high blood pressure is good because angiotensin 2 is a potent constrictor. Just it by itself will constrict the arteries. So for hypertension, good to block that conversion. We want that conversion here so we can maintain arterial pressure and increase the venous return to the heart. Unfortunately, increasing constriction has the added downside of increasing afterload. As we move further, angiotensin 2, converted to aldosterone, or prompts the release of aldosterone from the adrenal glands, and aldosterone is what does the job. Aldosterone is the factor that executes fluid retention. It prompts sodium to be reabsorbed at the kidneys, and then by osmotic pull, fluid follows suit. So sodium is returned into the blood, fluid is returned into the blood. Overall, we're attempting to increase preload. If we have more blood, the heart should have more of a substance to pump, according to the Frank-Starling law of the heart. The overall goal of fluid retention is to increase preload and thereby support cardiac output. The unfortunate consequence is that, sure, we do that, but we also drastically increase the afterload, or the work against which the heart has to pump. And it's this progressive cycle that leads to fluid retention and the congestion associated with congestive heart failure. And it's not really congestion, it just sounds like congestion, because all that fluid accumulates in the lungs. congestion, persistent cough, wet cough. That's where congestive heart failure gets its name. We have this chronic stimulus to retain fluid because the heart is clearly unable to pump enough blood. So if we retain fluid, hey, we should be able to pump enough blood. But that fluid accumulates in the left side of the lungs. Because the heart is weak, we can't leverage the extra blood that we have on hand to increase cardiac output. Because the heart is weak, the increase in preload isn't realized. Because the heart is weak, we have this backlog where we retain fluid in the periphery, and this is the aorta going out to the periphery. We retain fluid, and we have this backlog whereby the heart can't pump against that resistance, and so fluid accumulates into the lungs and eventually damages the lungs. One of the characteristic signs of congestive heart failure is some epithelial cells in the lungs will rupture, blood gets into some of the capillaries. That's not something that the lungs want. So macrophages, the immune system, attack the red blood cells and try to correct or reverse that situation. The alveoli don't want red blood cells in it to help maintain gas exchange. And so the macrophages consume red blood cells, and these individual little cells here are dead macrophages full of hemoglobin and red blood cells deposited in the lung tissue proper. They're called heart failure cells, or not called heart failure cells. They're called hemosiderin macrophages, but I'm going to call them heart failure cells, which is how they're better known, or commonly known. Sorry, Say, did you have a question?
I think maybe I just you said that there was red blood cells that went into the capillaries, but I think maybe you meant alveoli, and I was just going to clarify, but then you just kept
Yes.
going and said capillaries. Now, sorry, alveoli. Now it makes sense.
Right, that's right. They should be in the capillaries. That's where they're supposed to be.
Yeah.
In the alveoli is what I was looking for.
Okay.
Yeah, they damage the endothelium and can cross into the alveoli. Good catch. Dylan, question? Are you all right?
Just for testing purposes, do we need to know that they're hemosiderin macrophages?
No. And I didn't put it on here. The spelling and the pronunciation I'm not even sure about. We'll call them heart failure cells. Macrophages that consume the red blood cells to protect the alveoli, I expect. Yeah, Leanne?
So are you like too far gone at this point, or like if you got a heart transplant?
It's all over for you.
Good question.
If you got a heart transplant at this point, would like the damage to your lungs reverse, and if your new heart is okay, you'd be fine?
That is a fantastic question. I don't know if this can be reversed. If, for instance, it's like a scab on the inside of the alveoli that will resolve in time, and maybe some clotting cascade will help to decrease or break up these cells and reuse them. I'm not sure. Whether a heart transplant will allow you to survive or whether you're too far gone might depend on the extent of this damage. But certainly, if you corrected the problem of having an inadequate pump, in short order, I'd imagine it's likely you would excrete the excess fluid because your heart is now able to overcome that persistent increase in workload. So you'd excrete sodium, fluid would follow, that would return pressure to normal. Venous return would be adequate, that cardiac output could be maintained. I'd expect that replacing the pump would resolve a lot of the issues that you're having. It's simply that the pump is weak, that this cycle propagates and expands and rolls out of control. Yeah, Kristen.
So
So would a symptom of this kind of be like, would you cough up blood in this
Yeah.
situation? Okay.
Yeah, wheezing, wet coughs. You could cough out blood or what look like little coffee grinds, like little dark particles. That's a symptom of severely progressed congestive heart failure. Yeah, what does it?
Would death eventually result because you're sort of pneumonia suffocate or because the heart fails?
Both, and I don't know if one will always precede the other, but either could be a cause of death. Yeah, absolutely. And so you see this manifest as a wet hacking cough, a persistent cough, and you can see distension of the jugular veins because fluid doesn't only pool in the blood, but it also moves into the interstitial space, into the organs itself, and that compromises organ function. So this is an example of a fellow with a clearly distended jugular vein, indicative of progressed congestive heart failure. Yeah.
Would you see a change in the dynamic lung volume similar to COPD?
A change in dynamic lung volume.
Because some of the alveoli would be compromised.
Well, if the heart failure cells close off the alveoli or prevent them or reduce their compliance, I would say yes. But I don't know if that would be obstructive. I think it might be more restrictive. And that's just my guess at the topic. I'm not sure exactly, but I think it would be more restrictive.
Is that because there's so much fluid that's kind of preventing the lungs from expanding, or just because there's less alveoli to actually expand because they're full of the macrophages?
I think it would be because the alveoli are essentially cut off, right? It's not that there's something limiting airflow through a passageway. It's that the terminus, the volume at the termini has been reduced. Yeah. Yeah, I think so. We're going to go with that.
Would it be obstructive also just because there isn't any like blood feeding into those alveoli, even if they were able to expand, like the capillary burst, so they're not being fed with any blood?
Well, restrictive would describe flow of air being compromised. So the flow of air into and out of the lungs, as far as you would monitor that with the spirometry test, air could still move in and out to other alveoli that are not compromised. I see your point. Maybe there's an obstruction if the compliance of the lung globally is affected, and so as you try to increase the negative pressure and draw air in, flow is compromised because there is no compliance at the alveoli. I think long before that, though, you'd probably die. Yeah. There's no gas exchange. There's no ability to move air. I think long before that, you'd probably die. But I'm not exactly sure. That's a good question. Interesting idea to explore. So this is an inadequate pump. And the fact that the pump is inadequate, the compensation is inadequate, spurs this downward spiral, and all of these compensations worsen the situation. I would imagine replacing the pump would help correct that, but it's the inadequate pump. And that's what we're trying to mimic in lab when we talk about dehydration. When we do the second cardiac output lab with dehydration, we're trying to mimic the insufficiency of the heart. And it's not so dire as all that. Not to worry, Peter. Who's up this week, by the way? Anybody know?
I don't think this week is dehydration for either lab.
No, but lab group B is going, right?
Yeah.
You're going to go, Razan? Yeah? Make sure you're well hydrated. Yeah? 500 mils of water, starting about a lunch, 1 o'clock? Okay. So we're going to try to compromise your heart functions next week. And what I'd like to do, I haven't talked about this with Jody yet, but last week's lab went really smoothly from the sounds of it. Everyone was done pretty quick. So I think what I'd like to do is go back to the old setup of, instead of alternating weeks, the lab groups A and B, we'll just split the lab section in half, so you'll have 1.5 hour sections. Lab group A in the first hour and a half, so 2:15 to 3:45, and then 3:45 to 5:15 will be group B. And the reason for that is then you'll all have the data to do your final lab report next week. The deadline will be the following week, which is in advance of the lab exam. So lab group B is no longer handing in their lab report the day of the lab exam. I think that will probably help. I'm going to confirm that with Jody and make sure everything is okay with her, but there's no reason why we can't do that, in my opinion. So all groups next week, lab 5. Why is dehydration an appropriate method to stress the pump, to compromise the pump? I'm just going to show you briefly what happens to cardiac output normally and what happens to cardiac output when you're dehydrated. We'll look at the ingredients of cardiac output, heart rate and stroke volume. I don't have mean arterial pressure and total peripheral resistance, but you will find out how those change in lab. So I'm giving you the first half to show you what happens between labs 4 and 5, and then you're going to take the reins and figure out mean arterial pressure and TPR. And then I want to tell you why I think dehydration is an appropriate intervention to mimic the compromised pump that we observe with congestive heart failure. We're not making the heart weak, we're simply reducing the supply of blood, which is going to compromise cardiac output. Now I'm jumping ahead a few slides for those of you looking at the slide set online. And I don't want to spend a lot of time on this flow chart. It's pretty busy and it looks really small now that I see it on the overhead. But what this describes is the transition to exercise, the things that happen as you move to exercise. And so I just want to highlight a few of those things. And you can generally separate the graph into the top half is the transition to exercise. And then the bottom half here is maintaining exercise. And if the status quo is maintained, exercise carries on without a problem. The problem that we are going to institute is that the status quo is not maintained in dehydration. I'll just briefly explain that. So everything on the top left, and I'm taking out this right-hand part of the flow chart, everything on the top left here describes how flow and how pressure is regulated during the transition. So the first few things that happen with exercise is you know you're going to exercise, the brain starts to adjust flow. Central command starts to adjust flow. And what that means is everything constricts. Everything constricts when you move to exercise, which doesn't sound like an appropriate response until you consider that the muscles release metabolites that open up the vascular bed locally. And that's a really elegant way to direct flow to the working muscle. So we have constriction everywhere. Constriction everywhere. The skeletal muscle releases factors that open up that vascular bed. So blood doesn't go to things like the spleen, doesn't go to the intestines, it goes to quadriceps, hamstrings, soleus, working muscle. As that vascular bed opens, there is an initial drop in TPR. So I want you to look for that when you get to lab on Friday. Or you might have even calculated that in a normal situation with your lab 4 data. Maybe. There is an initial drop. After we've adjusted for this drop, we start to constrict the arteries. We maintain a higher pressure because now the set point is higher than at rest. We don't regulate at 120 over 80. We regulate maybe at 150 over 85 or 180 over 85. It depends on the intensity. But after we've found that new set point And we've adjusted pressure and flow accordingly. Heart rate goes up, force of contraction goes up, the constriction of the vessels go up. We're exercising normally, and the status quo here is maintained if nothing changes. Exercise can continue. What goes wrong is shown on the right-hand side of the screen. You get hot, right? You get hot when you exercise, and we need a way to avoid getting too hot. And so without going into too many of the mechanics of the reflexes for sweating, sweat evaporates from the skin, cools you off. We'll put it that way. At a certain threshold, whenever you get too hot, sweat gland activity picks up, blood flow to the skin is allowed, and this allows heat to be dissipated. You can lose body heat so you don't get too hot. The fluid for that sweat has to come from somewhere. And it comes from the blood, primarily. So in the context of everything working normally, pressure is high, venous return is adequate, heart rate is up, pressure is up, etc. As soon as you compromise blood volume, all of those other things are compromised as well. Venous return suffers, stroke volume drops, heart rate has to compensate. It's undetermined yet what happens to cardiac output. So taking fluid out of the system compromises the status quo. At the risk of complicating things, I'm moving on. So what happens then? In a normal scenario, we have this change in blood pressure normally. As soon as you move to exercise, let me just orient you with these graphs that we're going to look at. So this is a study looking at progressive dehydration. This is a group that drank a lot of fluid, slightly less, very little, and no fluid. So they were well hydrated and progressively more and more dehydrated as the groups go on. So all of the open squares or circles, I can't really tell, are the very dehydrated group. They should be the worst case scenario. And the closed circles are the well hydrated group. And that's really the comparison that I want to make. Well hydrated, normal scenario, dehydrated, your lab 5, compromised scenario. And in both groups, we see this initial concentration of the blood. This is a 2-hour exercise bout, moderate intensity, but there's no additional decrease in blood volume if you're well hydrated. If you don't replace any fluids, we see this progressive loss of blood volume over the course of 2 hours. And what that does specifically is compromise stroke volume. We see stroke volumes high initially, and it decreases a little bit, but it's pretty well preserved when you're well hydrated. In a person that's dehydrated, we see a much steeper drop-off in stroke volume. So losing fluid, having to secrete sweat, compromising blood volume means the heart doesn't see as much venous return. There's not enough blood going back to the heart, and so what happens? Stroke volume drops off. This is the Frank-Starling law of the heart in reverse. If you increase preload, you increase stroke volume. If you decrease preload, you decrease stroke volume. That's what we're showing here. Well, that won't do. We want to continue exercising. We want to maintain cardiac output. The heart senses that the pumping ability is compromised, and so it compensates at the heart tissue specifically by increasing heart rate. Right? Heart rate times stroke volume equals cardiac output. If stroke volume is too low, well, we can just increase heart rate to compensate. And we see this massive surge in heart rate in the dehydrated group. 165, 170 beats per minute, compared to 150 in the well-hydrated group at 2 hours. And this should be enough. You'd think it would be enough, but it's not. Cardiac output still continues to fall in the dehydrated subjects over 2 hours. This is an artificial congestive heart failure scenario. This is a scenario where all the methods of compensation attempt to correct the cause of the problem but end up making it worse. And so we have this decreased pumping ability. So we know, lab 5, when you're dehydrated, the heart can't pump as effectively. This should be a good surrogate for congestive heart failure. And at the risk of going off on a tangent, this is one of the areas that I really like, so I'm gonna go ahead anyways. You can entertain me. At the risk of going off on a tangent, the reason why everything seems to go wrong is, okay, so the body wants to maintain cardiac output. It increases heart rate as much as it can. What else can it do? Well, when I'm sweating, blood's going to the working muscle and the skin. I don't think I need to send blood to the skin. Let's just shut it off. And this is a measure, a surrogate measure of skin blood flow. If we measure flow at the forearm, it's a measure for whole body skin blood flow. And you can see there's a little bit of a separation. The dehydrated group sees less skin blood flow. The well-hydrated group maintains skin blood flow. So in an attempt to maintain cardiac output, we're turning off the valve that sends blood to the skin, trying to increase preload and maintain cardiac output. But the downside consequence is that compromises the ability to lose heat, and in all cases, you get too hot. We'll put it that way.
Is that just like internal temperature? Like would the person be cold to the touch since they're not really getting a lot of blood flow to their
No. Let's put it this way. It's internal temperature, and there's rectal and esophageal here, which show core temperature. There's still heat being conducted to the skin. There's some small blood flow. This isn't at 0. And there's also, because this is magnified, the tissues between the core and then the periphery will conduct that heat outwards. It's essentially like you're putting on a sweater, and you're just insulating yourself. So you get warmer from the inside out. It's not that your skin cools. It's just that it's not transmitting that heat to the periphery. If that makes sense.
Not bad.
It's not cool to the touch. You don't get colder. In a severe situation, you will stop sweating and you might feel clammy to the touch, but your skin will always be of a normal temperature. We'll put it that way. It won't be abnormally cold. And so we see this, this isn't really that important, but we see a progressive, nice relationship where the more dehydrated you get, the more the response is compromised. The hotter you get, the less you can sustain exercise. This mechanism sounds terrible, right? Why would you sweat? If all you're doing is compromising blood volume, reducing cardiac output, preventing yourself from cooling yourself during exercise, why would you even sweat? It looks terrible on paper until you think about the endurance ramifications. It's fantastic for endurance. We have evolved with this mechanism to be able to meter our performance, find fluid along the way, and maintain that endurance performance. It's really born out of our hunter-gatherer ancestry. And I like this point to ram home the idea that this is a very efficient manner for maintaining performance. It seems like it's going to compromise performance, but it's very efficient for maintaining performance. And a really interesting comparison is that of men versus horses, because both of these organisms sweat to cool themselves off. They sweat during exercise. They both need to rehydrate. They both need electrolytes. There's actually a new horse electrolyte supplement market, I think, that's been opened up in the past few years. One of the old profs I worked with at the University of Guelph did a lot of research in this area, and I think is making some nice bank in that area now, selling supplements for horses. But compare this, for instance, to dogs or sheep. Dogs, we know, don't sweat. They pant to lose heat. They can run quickly, but not for a long time. They have really poor endurance. So why am I showing you this comparison? Obviously, horses are faster. Obviously, we can't keep up with horses from an endurance point of view. They're larger, more muscle mass. But this mechanism allows both horses and men to perform similarly, I'll put it that way. And there is a race every year, actually didn't update these numbers for this year, that pits man versus horse in a marathon over the terrain. I think it moves around. I think it's either in England or there was one in Africa. But direct competition, man versus horse, in being able to run a marathon or pace yourself for a marathon. And you can see throughout the past 10 years or so, pretty comparable performance. The last human to win was in 2007, so I would give the edge to horses. But 20 minutes difference, 10 minutes difference, 15 minutes difference. This mechanism is really robust in maintaining endurance exercise performance. It's pretty interesting. And I was going to show you a video, but it's not here. Which is fine, because this is a little outside of our scope of practice anyways. There's a really nice clip from a BBC documentary a while ago that showed the origins of that sweating mechanism in the terms of hunter-gathering, and there's still some Kalahari bush tribes that use or leverage that endurance mechanism to hunt prey. Not working, so I'm not going to worry about it right now. Instead, let's summarize, and we'll call class somewhat early for the day. Way back when, we identified ECGs aren't always diagnostic. Sometimes you need a better measure of heart function. There are tests that evaluate function through blood and oxygen delivery to tissues, or through direct monitoring of the coronary arteries and then inference of how the heart might function, or through direct monitoring of the pumping ability of the heart and then estimating ejection fraction and calculating cardiac output that way. So there are more advanced tests other than ECG to evaluate heart function. Some of those we talked about at length are too expensive for us and are listed here in their ability to calculate cardiac output. So you could measure heart function either by trying to approximate the ejection fraction by direct observation using an echocardiogram, for instance. You could measure heart function through the old dye dilution or thermodilution techniques, which look to see how quickly an indicator is dispersed. If it's dispersed quickly, or if it's very dispersed, flow must be quick. If it's not dispersed, flow must be slow. Or the way that we're doing it, through the indirect FIC, or if you'd rather, more invasive technique, the direct FIC method, using O2 or CO2 as our indicators to estimate cardiac output or blood flow that way. For our purposes, with the indirect FIC, we used PCO2 as a surrogate is used to determine, and it approximates really nicely, both venous and arterial contents. Not at the same time, during the rebreathe procedure and normal breathing respectively. So PCO2, when we reach that equilibrium, is meant to reflect venous CO2 arriving at the lungs. And then normal tidal breathing, end tidal CO2, would reflect arterial CO2 contents leaving in the arterial circulation. So those calculations we've done at length, and you have probably worked on your set already. Group A and Group B will work on theirs tonight. Bring any questions back to class on Tuesday. We'll go through those in depth. Or we have gone through those in depth. We can address any issues that you have in class if you need to. Now, measuring cardiac function is great initially with no stress or in a bubble. We can measure it at one point in time or for a given load or workload, but it doesn't measure the adaptability or compensation by the heart, which we described here as changes in preload, afterload, and contractility. If there is an obstacle or if the heart needs to compensate for some change in pressure, these are the methods by which the heart will modify cardiac output to affect pressure. In a normal situation, these will be resolved immediately. Pressure will increase or decrease. It will return to the set point. Then preload, afterload, contractility are resolved and returned to normal. But in congestive heart failure, because of the persistent obstacle, whatever it happens to be, either inadequate blood supply to the heart tissue itself or constant high pressure over which the heart has to pump to supply blood to the body, that persistent, chronic compromised normal heart function decreases the pumping ability of the heart, and with the decreased pumping ability, we have a decreased cardiac output, and then that whole cycle we just explored in detail today magnifies and accelerates. And we'll leave it there, unless there are questions. No questions. Okay. Have a wonderful Thursday.